Hello and welcome to PCR TV at EuroPCR 2019. We have a wrap-up session of the Pascal mitral repair system symposium we just had. And my name is Volker Rudolph from the Heart and Diabetes Center in Bad Oeynhausen in Germany. And I'm pleased to be joined by two colleagues who have a vast experience in percutaneous mitral valve repair. Stephan von Bardeleben from the Johannes Gutenberg University in Mainz, Germany, and Jörg Hausleiter from the Ludwig Maximilian University in Munich, also in Germany. So we are talking about the Pascal device, a device that has been CE marked in February this year, and I think a device that has been eagerly awaited by the community. So Jörg, could you summarize what are the particular features of this device, what makes this special?
Well, the Pascal device is a new device which we can use for the repair of mitral valve regurgitation. What is very particular about the system is that it has a central spacer. The spacer enables that the leaflet can coap better to the device, and it also fills this whole of the regurgitant orifice. And I think what is really a major, two major points that makes this system different is that you can use the two arms independently, so that you can grasp one leaflet first, and then you can use the system to go over to the other leaflet and then grasp the second leaflet. And this will allow you to optimize really a good tissue insertion into the device, which will at the end result in a good MR reduction. And perhaps the last aspect which makes it a little bit different from other devices is that you can elongate the system in those very rare cases where you have some entanglement, for example, with the chordae, so that you can also get it very safely out of the mitral valve and start all over then. So this is, I think, a very important safety feature which has been, well, probably not that much looked at in the past.
Okay. So Stephan, based on your experience, what does this mean for patient selection for morphologies we might choose?
Optimal patient selection in leaflet therapy is always a clue to success, and it is a system that works both on functional disease as well as on degenerative disease, as we have some new features. In functional disease, we reduce the leaflet stress by using a spacer in the middle, so we don't have to adapt the leaflets actually one to the other. If there's a gap, for instance, of 3-4 millimeters, the leaflets are simply attached to the central spacer, which gives the sealing of the valve. We also have two different widths of the system. This means that the clasp system is smaller than the pedals, which are outside. As the pedals have a width of about 10 millimeters, it is clear that the preference for the system is the A2P2 position, so in the middle of the valve, where the system seems to be capable to treat actually most pathologies, including flail, degenerative disease, prolapse, as well as severe tethering of the leaflets in functional mitral regurgitation.
Mm-hmm. So Jörg, we have seen data from studies coming from the CLASP study. Could you briefly summarize the most important results of this study for the audience?
Well, the CLASP study is the CE mark trial, which was used to get the CE mark in February, and it included patients from Europe and the US. There were about 62 patients who were enrolled. 2/3 of those patients had a secondary MR, 1/3 had primary MR. And what was really nice to see is that the procedure was also very, very safe, as many other mitral valve devices can be used in the mitral space. So the complication rate was really exceptionally low. And then the other most important thing is that the MR reduction for both patient groups, for the primary and secondary MR group, was exceptionally good. We have an MR reduction rate at early after the procedure, but also then at 6 months with a 2+ or less MR grade of above 90%.
So Stephan, I mean, this raises a very interesting question. Jörg has mentioned it, 98% patients with MR of 2 or less and more than 80% with MR 1 or less even after 6 months. This is better somehow as what we know maybe from other comparable studies or registries. How do you explain these results?
So one of the issues is, of course, we're going and beginning in experienced centers. So procedural skills in the centers is important. We have to say that, of course, the individual experience with the new Pascal mitral repair system is not very high, but the overall experience in the mitral field in those centers is high. So this is one of the explanations for a good result. The second explanation is, of course, that we can specifically use these new features in optimization of the result during the procedure. So what we do is we seal the leaflet to the spacer, and we see that the spacer has a unique potential to reduce MR. So I think even more astonishing is the 86 to 81% rate of 1+ or none MR being stable up to 6 months. I think this is a very, very good result that has to be proven in larger series. But this is due, I think, to the unique mechanisms. And the second one that we also experienced in our individual center experience was that the optimization by raising one clasp and optimizing, putting the leaflet deep to the tip of the spacer actually improves the results dramatically. So in more than 60% of the cases, we actively optimize one side of the leaflet insertion, and this can change with the same position of the mitral repair system. It can optimize the result at least by 1 grade, and I think this is one of the reasons that we've seen such exceptional results that also convert in a very good KCCQ, actually a quality of life improvement, which is normally important after 5 points, and here we are up to 20 points improvements, which is also exceptionally high compared that we have 77-year-old patients here, and I think this is a huge change, and we have to get rid of the situation that we only think that MR is a topic. It's also clinical output and also clinical symptoms for the patients.
The other important thing is, or what was surprising also to me, is that we are able to get in the European experience now to those results with even only 1.2 devices. So that means that we can really, as Stephan pointed out, use this technique with the individual grasping to really get with one device the best result. If you're not happy with that, you still have the option to place a second device without having really some troubles with the gradients. So far we were very happy with low gradients after the procedure, but having just one device is probably a very, very good approach, because it leaves you also a large mitral valve orifice at the end, so that the patient has a good inflow into the left ventricle.
Stephan, you already alluded to it. What would you expect is the learning curve for the device in centers which already have experience with mitral clip therapy, and then also maybe in users that have not used such devices before?
I think anybody that has used different types of left atrial mitral valve devices so far will have an extremely low learning curve that is about 5 procedures, just to adapt slightly to the different techniques.
So maybe to conclude, a question addressed to both of you. Can you tell us what are the maybe 1 or 2 most important features that might be an advancement over systems we have so far? Maybe
well, as we both pointed out, probably the independent capturing of the leaflet is probably one of the big differentiator to the other systems available, and that really allows you, as pointed out before, to really optimize the results for MR reduction, which I think will at the end translate into an improved clinical outcome.
I would like to add the spacer and the pedal design. The pedal design actually taking off a lot of the forces inserted with a leaflet device to the leaflet itself, actually distributes this pulling force very nicely to the leaflet. So I think issues like leaflet rupture, etc., we almost won't see with this device, because it's specifically designed and covered to overcome such problems. So this would be my estimation in this regard.
All right, so thank you very much for this great discussion about, I think, an exciting field in interventional cardiology and a fast-moving field. And Thank you for watching and have a great remainder of the Congress.